So next slide, antihypertensives used for patients with low risk of coronary artery disease. Again, low risk of coronary artery disease. You're never going to give a beta blocker in this case. What is my goal? My goal is to be at least less than 140/90. What can I start you with? Again, if you have diabetes, you've got to start the patient on ACE. If you don't have any other disease states, you're always, again, going to start with a thiazide. Slide 16. Antihypertensives used for patients with high risk of coronary artery disease. Again, the patient doesn't have coronary artery disease, so don't start a beta blocker. What is my goal? My goal is to be less than 130/80. What can I give? Again, at this point, if you haven't started thiazide, you start a thiazide. If I have other disease states, such as diabetes, of course, again, you're starting an ACE or an ARB. Again, the reason we're doing an ACE and an ARB with diabetes is to protect your kidneys. So again, your goal in this time is less than 130/80, and we can start with ACE, ARBs, calcium channel blockers, and of course, thiazides. Slide 17. Antihypertensives in patients with coronary artery disease. Now that's really important. With coronary artery disease, am I going to use a beta blocker? Absolutely. In this case, I'm using a beta blocker. My goal is to be less than 130/80. Again, if you have coronary artery disease, your goal is going to be less than 130/80. You've got to know that number. Again, can I give a beta blocker? Absolutely. My drugs of choice in this case is going to be a beta blocker, an ACE. If I can't give an ACE, for example, they have, for some reason, really bad cough, and I've tried other ACEs, then you're going to give an ARB. So again, beta blocker, ACE, and ARB. Slide 18. Beta blockers or blood pressure meds with congestive heart failure. Again, blood pressure meds with congestive heart failure. What is your goal? If I have congestive heart failure, your goal is to be less than 120/80. If I have heart failure, again, that's important, that number is important, 120/80. What am I going to give if I have heart failure? We haven't studied heart failure yet, but when you think heart failure, the two medications that help with morbidity and mortality for heart failure are ACE or ARBs, so ACE and beta blockers. So ACE and beta blockers are always given if you have congestive heart failure. So of course, those are the two medications that you're going to add if a patient has congestive heart failure and hypertension. Slide 19. Medications. Beta blockers are no longer, again, recommended for initial treatment for uncomplicated hypertension. We already went through that. If you have uncomplicated hypertension, you're never going to add a beta blocker. What are you going to start with? We talked about it. ACE, ARBs, you can add calcium channel blockers. You can, of course, always going to add a thiazide, but we never add a beta blocker. Beta blockers don't work as well to prevent stroke and cardiac events in patients without heart disease. All you're doing is adding more side effects. Slide 20. Beta blockers. Beta blockers are recommended for patients with coronary artery disease, or if they, of course, have congestive heart failure. Beta blockers improve outcome in patients with angina, systolic heart failure, and after a heart attack. So, of course, we're going to start with our medications. Thiazides are the first group we're going to look at. You've got to know what's in what class. We've got hydrochlorothiazide. We have chlorothiazide. Hydrochlorothiazide comes in 12.5, 25, and 50 milligram tabs. You go up 12.5 to 50 milligrams QD or BID. Then we've got chlorothiazide. What you want to realize is chlorothiazide is the only thiazide that comes IV. Again, you have to know things that are different. So again, chlorothiazide is the only thiazide that comes IV. It also comes in suspension and tabs. Slide 22. How do thiazides work? Thiazides work, of course, on the renal system. They're decreasing sodium. They're basically taking water out with it. Slide 23. Side effects of these are really important. So what do? They're a diuretic. They're causing hypokalemia. Now that's really important. First of all, something causes hypokalemia. There's a lot of drug interactions I'm looking at. Hypokalemia also causes muscle cramps. Of course, we know, what are you going to recommend? Tell them to take bananas, potassium supplements. You might want to tell them to have apricots. And of course, those don't work. You're going to add, for example, a potassium-sparing diuretic. Hypokalemia may also cause torsades and arrhythmias, so you've got to monitor for that. When I talk about drug interactions, the one drug that you don't want to forget is digoxin. Digoxin is very correlated related, toxicity is related to hypokalemia. So if you know of a medication that causes hypokalemia, such as a thiazide, you know it's going to increase dig toxicity. We have hypercalcemia. Now the one big difference between loops and thiazides are that loops cause hypocalcemia, while thiazides cause hypercalcemia. Again, loops cause hypocalcemia. That's a big difference between the two. The rest of the electrolytes are the same, but loops cause hypocalcemia, and again, thiazides cause hyper. The drug of choice for hypercalcemia is loops, such as Lasix. All right, so again, thiazides cause hypercalcemia. We've got hypomags. We have hyperuricemia. Why is that important? Well, if a person has gout, they have hyperuricemia. Now, if you have hyperuricemia, it doesn't mean you have gout. But if you have gout, you definitely have hyperuricemia. So if a patient keeps on coming in having gouty symptoms, you have to look at the medications. Is it the medications that's causing hyperuricemia? And of course, additive. There are certain medications that are additive of side effects. So we know thiazides increase hyperuricemia. We know other medications cause hyperuricemia, as we'll be seeing. Some examples: niacin causes hyperuricemia. Low-dose aspirin, not really low dose, but less than 2 grams of aspirin causes hyperuricemia. Busulfan, which we'll see when we talk about chemotherapy, causes hyperuricemia. So there's medications, again, that are additive, so you've got to watch for that. Glucose intolerance. What you've got to remember about this glucose intolerance is that you have a cell. For a unit of insulin to go into the cell, you need a unit of potassium. If I don't have that potassium around, I can't take that insulin into the cell. So anything that causes hypokalemia can cause glucose intolerance. So in this case, what's important to remember is that if you have diabetes, for example, it's not contraindicated to give a thiazide. All you have to do is monitor their potassium. If their potassium doesn't go down, it's not going to cause glucose intolerance. Again, one more time, for every unit of insulin that goes into the cell, it needs potassium. If I don't have potassium around, I can't take that insulin into the cell, therefore causing glucose intolerance.